Hello, and welcome to Ask Your Liver Doctor's webinar series. This is Farah Douglas, President and CEO of the Liver Health Foundation. We are a California-based nonprofit foundation and focused on California liver patients. So thank you for joining us. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for equity in access to healthcare, and host patient and physician-centered educational programs. We are already working on our 2026 program, in-person events, and educational webinars, and we will post them on our social media and our website. Our website address is liverhealthfoundations.org. Tonight's webinar is about LAL-D, or Lysosomal acid lipase deficiency. This is a rare disease, and we don't hear about it much. LAL-D is considered a key differential diagnosis in patients with unexplained liver disease, particularly those with cryptogenic cirrhosis or non-alcoholic steatohepatitis, especially when no other common cause for liver disease exists, such as obesity, diabetes, or hepatitis. So tonight is a great opportunity to hear from our expert physician about this disease. Our goal in hosting these pre-webinars is to raise awareness of various forms of liver disease and to make sure that you get all the updated and accurate information. We thank our physicians, medical centers, liver patients, and pharmaceutical companies for their support of our efforts. Now, disclaimer. Please remember, information given by our experts is not substitute for advice given to you by your own physician or healthcare provider. Now, we are very lucky to have sponsors for this program. We thank Alexion, AstraZeneca Rare Disease, for supporting our efforts and for helping us raise awareness of liver disease. It is now my pleasure to introduce Dr. Rohit Kohli, MBBS, MS, who has generously accepted to be the presenter for this program. Dr. Kohli is MBBS, MS. He is the Chief Division of Gastroenterology, Hepatology, and Nutrition, Associate Director, the Saban Research Institute, Associate's Chair in Liver and Intestinal Research at Children's Hospital, Los Angeles, Professor Pediatrics, Clinical Scholars at the Keck School of Medicine, University of Southern California, USC. Dr. Kohli's research work has focused on the pathogenesis of obesity-related liver disease, LAL-D. His lab has specifically investigated the role of the acid bile acid signaling as a mechanism for LAL-D and regulation of this extreme stage of this disease, which is steatohepatitis. Dr. Kohli studies liver lipid biology, including disorder of lipid transplant, such as LAL-D. He has published more than 160 peer-reviewed articles, including in prestigious scientific journals such as Nature, Nature Preview, the Journal of Biological Chemistry, Gastroenterology, Hepatology, Journal of Pediatrics, and the American Journal of Physiology. Dr. Kohli is a recipient of the 2007 George Ferry Young Investigator Award from the Children's Digestive Health and Nutrition Foundation, a fellowship award from the American Association for the Study of Liver Diseases, AASLD, a Kidder Research Innovation Award from the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Foundation. Dr. Kohli is a member of the American Pediatric Society, National Academy of Medicine in India, and Liver Health Foundation's Medical Advisory Council. We were proud to have acknowledged Dr. Coley's distinguished and exceptional service to our community and liver patients by offering him Liver Health Foundation's 2022 Healthcare Visionary Award, a recognition well deserved. Dr. Coley, I am going to stop sharing and we are ready for your presentation.
Thank you, Farah. That was, as always, a very kind introduction from your side. Let me see if I can share my screen properly. Let me know if you can see the full screen version.
All right. It's not full screen yet.
How about now?
No. It got smaller, actually. Okay, that's good.
Perfect. It takes a couple of clicks and then the timing itself. Well, thank you again for inviting me to talk about a subject that I have closeness to. Lysosomal acid lipase is definitely an enzyme that is important in lipid transport. And when you are deficient in it, of course, then you have this disease called lysosomal acid lipase deficiency. We've already learned about who I am, and that is, of course, the topic that I am going to speak at today. Here are a few of my disclosures, and also a disclaimer from my institution, Children's Hospital Los Angeles, at the bottom of the slide. I will want to point out specifically that the company that initially worked on the treatment for lysosomal acid lipase deficiency, Synagiva, which was then subsequently converted, the company changed hands to Alexion. I did consult with them in the past. I'm currently not consulting for them. So today's outline, I would like to give you an overview of lysosomal acid lipase deficiency, and then I will go over the specific impact on liver and liver disease when you have this deficiency of the enzyme lysosomal acid lipase. And then finally, also try to give you a brief overview of what can be done to treat in today's world, if you are diagnosed with, or one of your loved ones, unfortunately, is diagnosed with LAL-D. I'll continue to call it the short form going forward. So LAL-D is, of course, a genetic disease. You need to have two hits, unfortunately, both from your parents' side, to generate a disease physiology. And it leads to the accumulation of a special form of cholesterol called cholesterol or cholesterol ester, CE for short. And when you accumulate a lot of them, you can have them cause significant damage to different parts of your body. If one considers the penetration or the presentation of the disease, there are two types of, broadly speaking, presentations. As a very young infant, sometimes as a neonate, one can present with a severe disease, and that was identified initially and classified as Wolman disease, Wolman. More older children or adults can present as well with more subtle or slowly progressive disease, and that used to be called cholesterol ester storage disease, or CESD for short. Both of these disease presentations, whether in infancy or young childhood, adulthood, is caused by the same mutation in the same gene called the Lipase gene, which encodes, of course, for the LAL enzyme. Disparately, whichever way you present, there will be injury to the liver and unfortunately also cardiac, GI, and spleen manifestations. So it is a multi-system disease. And the spectrum in infancy, in neonates, it's very, very rapid, and it's an emergency, right? You can have liver failure and unfortunately under a year of age, mortality as well. For children and adults, it is either a fast progression if you present as a child, or a little bit more slower, insidious if you're presenting as an adult. However, you can see that the liver affectations and the lipid affectations are common. In the more aggressive, progressive form in childhood, you will have liver and spleen enlargement and growth failure, in addition to the changes in lipid metabolism and blood tests in lipid, which I will go over more detail later. In the adult form of presentation, you will maybe just present with elevated liver blood tests, in addition to the cardiovascular injury and atherosclerosis or plaque formation in the heart vessels. The prevalence, and there's going to be questions about this, is not exactly known. It is a rare disease. There's some disorders which are listed on top in terms of genetic changes, but approximately the best understanding we have is about 1 in 150 to 130,000. That's the variation in terms of at least European ancestry for the birth prevalence. And you just specifically look at the neonatal emergency form, which used to be called Woolman's, it's more in the 1 in 700,000 newborns. When you look at the first reported manifestation of LAL-D across the age spectrum, a lot of the presentation will be in the pediatric age group from under 12 years of age. You can add these numbers very quickly, and you'll see that we're dealing with pretty much a 75 to 80% of the presentation of the first clinical sign all the way at the front end of the age group. However, that does not mean that we cannot find people older. And you will see that there are some significant 5 to 6% that all the way up to 58, 60 years of age, we can find them. When you look at the mortality in the very young age group, the infantile version of LAL-D, which used to be called Woolman's disease, it's pretty rapid. As you can see in age on the x-axis in the first graph on the left here, by 12 months of age, we have from 35 children identified infants, only 4 surviving. So very high rate of mortality in this cohort. When you look at the liver transplantation, and again, from the first manifestation to getting transplanted, you will see we have a lot of these children at that time who are identified within 3 years of first manifestation. Half of them are either going to fibrosis, cirrhosis, or liver transplantation. So even in childhood, very rapidly progressive disease. And why is this happening? What's happening at the cell level? I'll briefly describe what is a healthy um, uh, uh, physiology, normal lipid processing inside the liver cell, or what we in the technical side call hepatocyte. When we see that here, the organelle, the biggest circle here is the liver cell or hepatocyte. In the smaller oval shape here is the nucleus. And another brightly colored, lighter colored white circular structure is the lysosome. So remember, LAL, you're talking about lysosomal acid lipase. So there is this organelle called lysosome. That's where we take free cholesterol, FC, or fatty acids, FAs, these upward green arrows, go inside the lysosome organelle, which is inside the small cell, the liver cell, and that converts your fatty acids or free cholesterol into triglycerides. However, the problem, if I go into this situation where you have a problem, now we've moved over from normal to abnormal, where you have low levels of free cholesterol being released or fatty acids being released, and you have an accumulation of these cholesterol esters. That is where, when you have the lack of the LAL enzyme, you end up with loss of function of the LAL enzyme. And that leads to these increasing levels of cholesterol esters, these green globules, and triglyceride, these blue globules. And that is the problem, where the lysosomes become bigger and bigger, hypertrophy within the cell. And that leads to an upregulation of more, sadly to say, the bad cholesterol, LDL cholesterol, and that together is the basic problem in LAL deficiency. So when we start to see that happening on the cellular level, what is happening at the organ level becomes manifest. 87% of patients who have a diagnosis of LAL-D will have cardiac heart manifestations. Not only do they have high levels of the bad cholesterol, LDL, but they also have low levels of the good cholesterol, HDL. This combination is not good for anyone's heart vessels, and they develop coronary artery disease, heart blockages, or strokes, or aneurysms, or heart attacks. Myocardial infarction can happen. When you think about the spleen size starts to get bigger because, again, these abnormal cholesterol deposits, cholesterol esters, start to accumulate, and you end up with a larger spleen. And the problem with that is that the larger spleen starts to trap your white cells and trap your platelets, normal cells that are circulating in the blood, prematurely decreasing the levels of both of them. We call that hypersplenism, a hyperactive spleen, so to speak, and you have anemia and white cell drop or leukopenia or platelet drop or thrombocytopenia. And this, of course, is a risky thing because you need those cells for preventing of bleeding and so forth. And if the spleen is too big and you get injured, which is on the left side, you can end up with splenic rupture, and that is a very dangerous emergency. So sometimes we have to take the spleen out to treat it, or called splenectomy. In the GI tract, in the intestines, you start having deposits of a lot of these cholesterol rich deposits, and you start having nausea and diarrhea and failure to thrive because absorption is impacted. And of course, it's not in every person who has LAL-D, but at least a fifth, 22% in this study. So if you put all this together, you're ending up with a lot of problems across the liver, heart, spleen, and intestine. I will talk now next about the liver-specific problems. This is the Liver Health Foundation, and I'm a hepatologist, so we have to talk about a little bit about specifically what this disease does in the liver. So unfortunately, 100% of patients that were in the study were found to have liver problems. Specifically, again, this accumulation of the specific form of cholesterol esters, which is very pro-inflammatory, and triglyceride accumulation, both in the liver cells and also in the resident macrophage type cells called Kupffer cells. And this leads to high levels of small droplets of fat, microvesicular fat, and that leads to this inflammation, and this cholesterol ester triggered inflammation leads to fibrosis and to cirrhosis, and then consequences of cirrhosis, of course, in the normal form of when the liver starts to shrink, the pressure builds up backwards and you have portal hypertension, large spleens, and unfortunately, long-term liver failure. So the natural history of individuals who have LAL-D deficiency, specifically for liver damage, you start to see 50% death rate due to liver disease under 21 years of age. Very, very rapidly progressive problems. And you can see this kind of jumping off from steatosis to fibrosis to cirrhosis, and then sometimes needing liver transplantation. And you can see the different stages at the bottom, where this study talks about how many percentage of the patients had steatosis at what time point, fibrosis or cirrhosis, and what ended up almost 13% requiring liver transplantation. So there are, of course, a broad diagnostic categorization of why you can have steatosis. And the bigger problem in our community today, of course, in terms of prevalence and incidence, is fatty liver disease, or what we call MASLD now, metabolic dysfunction associated steatotic liver disease. But the key word is steatotic, or steatosis, meaning increased fat in the liver. And early on, we used to call it NAFLD-NASH, and more recently, we call it MASLD or MASH. But the way the individual presents is the same as all of these other types of disorders. NAFLD, NASH, MASLD, MASH is common, but these other conditions with drug toxicity or diabetes or LAL-D all also can present with similar situations, where you have small droplet fat or large droplet fat, where you have these inflammatory infiltrates and then bridging fibrosis developing. So we really need to understand that sometimes in a clinic where you are focused on seeing individuals who are coming for fatty liver, you may find individuals who actually or both have fatty liver and lysosomal acid lipase deficiency. So even in pediatrics, our Pediatric GI Society, NASPGHAN, in our guidelines, we have lysosomal acid lipase deficiency as a condition to check for if a child comes to us with elevated liver enzymes in the setting of obesity. And also the European guidelines in adults also talk about it for inborn errors. So how do we distinguish? Of course, we can think about LAL-D patients usually having high LDL type cholesterol, which is usually not the case with fatty liver disease. But at the end of the day, sometimes we have to do testing. Here's two different diseases that can present similarly. LAL-D is what we're talking about, the high. The second is Wilson disease, which of course more well taught for longer standing all the way back as a copper metabolism defect. But you can see that the prevalence here is 1 in 70,000. So it's about twice less prevalent if you go by the disease data out there compared to Wilson's. But still, if you're going to find two Wilson's patients, you will find one patient with lysosomal acid lipase deficiency. So the basic message would be, please rule out lysosomal acid lipase deficiency, LAL-D, when you are thinking about other factors that can produce these similar symptoms of dyslipidemia, abnormal lipid numbers, or large spleen and liver. Now, when you get to the point where you are narrowing down to these storage diseases with large levels of spleen and high lipid levels, rule out lysosomal acid lipase. It's not very difficult. There's a simple enzymatic blood test that can be done for this, looking at the actual enzyme level, so to speak. So you have the diagnosis, you made it. What can we do today? The last part of my talk. So there is a treatment now, but how did we get there? So sibilapase alpha is a recombinant human lysosomal acid lipase. We took the gene sequence from the amino acid, expressed it in hen oviduct cells, reproduced it, and generated the enzyme. And when you give back the enzyme, I won't bore you with all the different steps that are needed, you end up fixing the problem of the accumulation of the increased amount of cholesterol esters inside the lysosomes. And when you do that, this is a nice representation of, at the cellular level, what is happening. However, more importantly, what you can see is here where you have normal levels, you're able to recapitulate the normal levels after you correct the intracellular enzyme deficiency of actual LAL, lysosomal acid lipase. And when this was tested in a phase 3 trial, this is back in 2015, there was a very seminal publication that came out by Dr. Barbara Burton's leadership, phase 3 trial of sibilapase alpha in patients, both pediatric and adults. 66 patients were treated with LAL-D, who had LAL-D with sibilapase alpha. And what they showed, as you can see here, there was an initial double-blind period and then an open-label period. But as soon as they were treated, whether in the double-blind treatment group or in all of the patients, when they opened up the treatment beyond 22 weeks, you have a decrease in the liver enzyme ALT as a marker of liver improvement. And here are the specific numbers. ALT normalized for individuals who were in the sibilapase alpha group by 31% compared to 7% in the placebo group for the initial period. Not only that, we also saw improvement in liver fibrosis. It's just amazing to see that the improvement was happening at all levels. There was no increased signal of AEs, as adverse effects or serious adverse effects either. The specific ones are listed, but the ratios or the percentages were not very different. This is a patient that I'll leave you with this message that if I can diagnose a patient, you can diagnose a patient too. We published this back in 2016 in the journal Pediatrics. A 16-year-old female came to us. At that time, she had a urinary tract infection. And when you have that, sometimes we will investigate further. We got an abdominal ultrasound. And while we were looking at the results, we saw that the spleen was very big, which is not typical for someone who just walks in with a urinary tract infection. The liver team was consulted, and we went about our usual, as I showed, the very long list of ruling out what is the cause of liver enzyme elevation. And we found that, we didn't have any major hepatitis infections. And so the child was overweight. We counseled and said, why don't you lose weight? Looks like you may have fatty liver disease. The child was very conscientious. They decreased their BMI by almost 10 points, 10 kilograms per meter squared decrease. But despite that decrease in body weight index, body mass index, their liver enzymes continued to be elevated and their lipids were abnormal. So we said, well, this is not your typical response to such a decent amount of weight loss. We therefore looked for alternative causes, more rare causes like Wilson's disease or lysosomal acid lipase deficiency, and her LAL-D level, her LAL level was low. And subsequently, this was proven on liver biopsy. As you can see, there were small vesicular droplets. It was accumulation of cholesterol esters on electron microscopy in this black and white image. And the genetics also showed a problem with the LIPA gene. Individual was treated with lysosomal acid lipase recombinant enzyme, sibilipase alpha, and completely shrunk the spleen down to within almost normal size. So to conclude, cirrhosis and marked lipid abnormalities are common as presenting symptoms for lysosomal acid lipase deficient patients. Can present late all the way into the 30s and 40s. So keep our eyes and ears open as clinicians. And we have a treatment. Sibilipase alpha significantly improves the hypercholesterolemia, reduces the fat content, and also can shrink the spleen size. So saving someone for, say, from a liver transplant. And I will stop here, and thank you so much for your attention.
Thank you so much for this wonderful information. And it's a disease that we don't know much about, but so important. And we will get back to this issue, especially about infant dying. So before we are going to embark on our roundtable discussion now, but before we do that, please allow me to introduce Dr. Sean Chandna, who will be participating in our roundtable. Dr. Chandna, sorry, I went too fast. Dr. Chandna, DO, FACP, AGAF, is attending physician, Division of Gastroenterology, Olive View, UCLA Medical Center, Health Sciences Associate Clinical Professor at David Geffen School of Medicine at UCLA. Dr. Chandna earned his Bachelor of Science in Microbiology, Immunology, and Molecular Genetics at the University of California, Los Angeles. He received his medical degree with honors from Western University of Health Sciences. He completed his residency in internal medicine and dual fellowship in gastroenterology and transplant hepatology at the University of Cincinnati. He is board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Chandna has held faculty position at the University of Utah and the University of Cincinnati, where he was assistant professor of medicine. He served as assistant fellowship director for gastroenterology at the University of Cincinnati. He co-developed the multidisciplinary liver tumor clinic at the University of Utah Huntsman Cancer Institute. Dr. Chandna is a member of the Liver Health Foundation's Medical Advisory Council. You're welcome. Dr. Chandra, thank you for joining us. And we will start our discussion on our LAL-D, and hopefully we will get some good answers from some of the questions. I had sent the questions to both of you. If you don't mind, I want to start with talking about newborn testing, screening for LAL-D, because from even what you were talking about, I saw that, Dr. Cody, a lot of kids die early, prematurely, but because they have not been diagnosed. So if you can start by answering that, and then hopefully Dr. Chanta will jump in.
No, it's definitely important to diagnose LAL-D as soon as possible, given that there is a treatment and the disease, especially in infancy, can progress very, very fast. So there is a dried blood spot test, almost like we do a heel stick for a lot of different diseases at that time period, where you can pick up the level of the enzyme and diagnose it. So it's very straightforward, very simple, and should be done whenever there is a suspicion.
And is it being done, though? There was a question that we had from parents that it looks like it has been a battle to make sure it gets done.
Well, I think they may be talking about including this in the official governmental newborn screen, and every state is different with that. Every state has a different number of diseases that are tested, but it is practically available and possible to do the testing, but to be included in the formal newborn screen, that's a state by state and sometimes national, federal level decision, which I can't comment on here.
Dr. Shannon, you want to say something on that?
Yeah, well, no, I won't, take away from what Dr. Coley had said about newborn testing. I think he's a pediatric expert, and that's best handled by him. But I did want to say this is a really rare and interesting disease to hear on the adult hepatology side. I'm in the adult space, and I think that we are becoming a little bit familiar over time, but clearly there's probably a lot of underdiagnosis and underrecognition. And, I do think this concept of seeing if the clinical profile fits MASLD MASH is something very important for us as clinicians to see patients and say, well, your lipids may not be improving with your therapies or may not be improving with your weight loss for your liver tests. And, is there something else going on? I'm just curious, Dr. Coley, I have tested some patients before. They've come back as carriers. They have not come back as fully autosomal recessive. But in your experience on the adult side, or when you see these folks a little bit later onset, what kind of clues you in to when we should be recognizing these patients have this and really doing the testing? Would you say it sounds like maybe to test everybody up front, or is there more of a clinical profile that you would look for to say, you know what, this is important to look for secondary causes?
I think that's a critical question. My typical kind of algorithm is to address the biggest problem in the room first. That's more likely 90+% of the individuals that come to our MASLD clinics will have MASLD because they're being referred with elevated liver enzymes in the setting of being overweight or obese. However, if they do not improve their liver enzyme elevations despite losing weight for a certain percentage, you can pick 5–10% of their excess body weight, and they still have elevated liver enzymes, then my antennae go up as to you've lost weight, but your enzymes are still as high as they were or worse than when you came to me in the first place. That's when I start to look for even more rare causes than usual. I would call it like a second line set of testing. And that's where LAL-D, for me at least, falls into. And the biggest tip-off, of course, is splenomegaly outside of the proportion to liver disease and or elevated LDL cholesterol in comparison to triglycerides.
I thought that was very interesting about the splenomegaly because oftentimes, in most liver spaces, we clearly associate splenomegaly with this risk of portal hypertension and likely underlying cirrhosis, although it sounds like in the pathophysiology here, this can occur independently. I'm
Correct.
also curious, when you see these patients, you said there's a rapid progression that a lot of folks, 50% of them have fibrosis, cirrhosis, or need for transplant within 3 years. But in terms of the later phenotypes of onset, do we know what the risk of progression is, how accelerated it is? Should we expect that most patients are cirrhotic by the time they see us as adults, if it's occurring at that point, or is it kind of unclear as to rates of progression for later onset?
I think all we have to answer those questions is cross-sectional data, and therefore the unfortunate thing is that we may be looking at different parts of the elephant, so to speak, when we are blinded by those cross-sectional pieces of data. Looking at the very young infants, they're dramatically sick when they are identified, and the children we identify, our young adults, have the splenomegaly and cirrhosis. But is that more of a presentation bias, that that's how their disease has progressed and that's how we're identifying them, versus the older adults that are being identified have slower disease progression, and therefore when we do pick them up, they have more subtle signs because they had slower progression. There has probably been a need, and somebody, not me, at being a pediatrician, should look into the cryptogenic cirrhotics who get transplanted for unknown reasons and see how many of them, as older adults who are getting transplanted for cryptogenic cirrhosis, how many of them had either carrier state or deficiency of the LAL enzyme.
Yeah, that's a very interesting question. And I think you're right. We've really assumed and labeled all cryptogenic cirrhosis to be likely from LAL-D and MASH. In terms of elastography and other methods to stage fibrosis, I mean, one thing I'll say, I found it very curious about the microvesicular steatosis, because there's very few things that will cause predominantly microvesicular steatosis, whether it's Rey syndrome or certain drug injuries or this. So it's a clue in. But I don't know that we have enough data on elastography testing. So I'm just curious, in your own practice, how do you stage these patients? Are you using MRE? Are you using, VCTE? Are you doing a biopsy and saying this is the best tool? Or how do you typically stage
Yeah,
them?
I think for diagnosis, as a tip-off, if you have a biopsy and it shows predominantly microvesicular, because you could still have some macro if you have obesity in the milieu, predominantly microvesicular or predominantly mixed picture, one should consider LAL-D testing, and good histopathology, especially if EM is done, can pick up on the cholesterol ester crystals as well. However, the diagnosis still will be made only on the lipogene sequencing. When you're thinking about long-term follow-up, if the individual is over 30 BMI, it could be hard to use, especially in a younger child. We have difficulty in getting a good VCTE read. So we fall back on MR elastography for a chronic liver disease progression and monitoring if you are overweight, obese beyond 30 BMI. I defer to you on the adult side what your cutoffs are, but I think as you get super obese, type 3, type 4, probably VCT becomes harder to utilize as well.
Yeah, I mean, I think largely elastography has replaced a lot of biopsy in the adult world. It's kind of unclear to me as to whether or not all the fibrosis data is captured by this specific syndrome with mostly microvesicular steatosis. But I think in the interest of not biopsying most of our patients, we have been defaulting to non-invasive methods. You mentioned about carriers, and I had spoken to you that I have seen some carriers, but I never really consider them as having a true risk for it. I'm curious, in your own assessment, this may be a harder question to answer. Do you feel like carrier deficiency would put somebody at a partial risk? Something kind of like akin to an alpha-1 antitrypsin deficiency, where you're a carrier state, maybe a secondary contributor of disease. What do you think about this? I know it's a harder question.
I don't think it's an inappropriate question. I think it's just a question where we don't have data that backs up any answer. However, I agree with your hypothesis that we're probably looking at a disease modifier similar to A1AT, ZZ, or SS phenotyping. We have now discovered does in conjunction with MASLD for instance, I think this would be a similar potential hypothesis of a synergistic heterozygosity, where while you have a carrier state for LAL deficiency in the setting of MASH, you have a faster progression, for instance. It's a good hypothesis. I just don't have the data to share.
It's an interesting question. I just kind of bring it up as something to think about, and there really no clear answer.
Yeah, and it's the same hypothesis that I mentioned before about the cryptogenic cirrhosis. It's probably a similar thought process there.
We have a question from Dr. Soban, who has sent in. He's asking, please talk about experience on the long-term efficacy of enzyme replacement therapy in CESD, and also, in that, and also here, question was that, is there any indications and timing of liver transplantation and or bone marrow transplantation for CESD?
So I think one has to understand that the limitation overall is that we really have about 10 years of real life or real world data right now. The approval for the product that was tested came after the phase 3 trial I showcased from Barbara Burton's leadership from University of Chicago. And therefore 2015 and 2025, there's 10 years of data and not much more. And in my personal experience, it has been beneficial. As I mentioned, spleen size goes down, lipids get better, liver enzymes improve. However, the length and depth of the data monitoring is since the FDA approval. So we definitely have to wait longer to understand what impact there will be on, say, liver transplantation. And the second, and probably caveat that is even bigger, is that we never knew outside of the cross-sectional data a actual natural history understanding of this disease. So we are hampered by those two limitations when to try to answer this very important question. I don't know if Dr. Channa has other thoughts.
No, I would completely concur with your answer.
So when they go on this medication for that they call them enzyme replacement therapy, does that bring the, I think you mentioned that it makes the spleen smaller again, and how does it impact the other parts of the other organs that have been impacted by LAL-D?
I think it's definitely improving the liver enzymes. We have data for that. To Dr. Channa's point, we may not have strong data of rebiopsies in a lot of these liver biopsies of many of these patients for the right reasons, but we need to accumulate data on fibrosis stiffness measurements either through MR elastography or vibration-controlled VCT or FibroScan type devices. Whichever modality is used, the spleen size is easier to measure, of course, clinical exam-wise and imaging. And last, but I think probably one of the more important ones is cardiovascular health, whether you have more or less cardiovascular events such as myocardial infarction or stroke from atherosclerosis that is known to happen, but is there a long-term advantage? And so those questions need time to monitor and goes back to the phase 4 monitoring we were just talking about, that right now we are only 10 years out.
Dr. Chandra, anything?
No, I mean, I would agree with your answer, Dr. Kohli. I had a question for you. As you mentioned cardiovascular risk, and nutrition is often something that comes up when we talk about lifestyle interventions with many of our adult MASLD patients. We are often recommending a Mediterranean diet. It sounds like this is really a buildup of cholesterol esters and triglycerides within the lysosomes. And so do you advocate primarily for, low-fat diets, or do you specifically talk about the Mediterranean diet? What do you do in terms of your nutritional counseling for your patients?
I fall back on more of a low carb, not a low fat diet, because again, yes, low cholesterol is important, especially when you're talking about cholesterol esters, but we have to remember that a lot of the lipids that we generate are coming from carbohydrate ingestion, de novo lipogenesis. And triglycerides also do accumulate inside those lysosomes in addition to the CE cholesterol esters. So both are things that we need to tackle. So in terms of decreasing cholesterol, yes, but also decreasing refined sugars, which overall will hopefully also lead to lower BMI. And if there is a secondary effect from being overweight, obese, you're tackling that in the context of having lysosomal acid lipase deficiency.
And it sounds very much similar then to the dietary advice that we give most of our patients who have steatosis under the broad terminology of steatotic liver disease. With regards to cardiovascular risk, do you find that these patients are at very high risk of cardiovascular mortality, similar to steatotic MASLD patients? Is there a particular risk of MI, stroke, or is it all in the nature of cardiovascular health with dyslipidemia?
There is increased risk for cardiovascular events, both MI and stroke. I'm hard pressed to say whether we have true understanding of whether it's going to be layered on top, almost like we were talking about liver disease as a first layer being what your overall body mass index and or body habitus is generating. On top of that, you have a secondary propensity through LAL-D. However, pure LAL-D cohorts already compared to the general population that is not lysosomal acid lipase deficient have increased atherosclerotic risk and more MIs and more strokes. So that is one of the features that we do understand from whatever small amounts of natural history data we have.
Thank you for answering that.
Are there any side effects of using this enzyme replacement therapy and for the long-term use? If a person gets on this medication, do they have to stay on it all their life?
For now, unfortunately, yes, you're talking about enzyme replacement, not genetic therapy, right? The beauty is that we have been getting more and more success through gene therapy. So at some point, if we can have a gene therapy analog for what we have right now, which is enzyme replacement therapy, then you could be thinking of a long-term solution without repeated infusions or treatments. Till then, enzyme replacement therapy means you have to keep giving the enzyme over and over. And that's the only way to treat it, which did not exist before, by the way. So it is a step in terms of progress for individuals suffering from this disease, but it is a limitation as well. In terms of side effects, of course, that's just like any other infusion-based therapies. You can have anaphylaxis and rare reactions in certain individuals, which will have to be monitored and addressed. But specifically, not dissimilar to other ERTs that are used today.
So, Dr. Coley, on that note, I haven't had too much trouble when I was previous at my institution at Utah and ordering LAL-D. I did it through ARUP. Have you had any issues ordering testing here? How easy is it to access as far as diagnosis and as far as enzyme replacement therapy? Have you had a lot of practical challenges obtaining the enzyme replacement therapy or not?
I think it's pretty straightforward to test. You mentioned one commercial entity, our institution. We have it in our electronic medical record as to how to order it, and it comes back pretty good turnaround within 4 to 7 business days, as far as I recall in terms of my experience. So it's not immediate, but it's not too far out in terms of turnaround. The treatment itself, of course, most insurance companies will require genetic confirmation before they will take care of the what you might call approval, prior authorization. But once that happens, that I think we've not had issues.
Well, it's great to know that our patients can get access then.
And there is only one medication right now available for LAL-D,
That is
correct?
correct. That is correct.
So if a patient that has LAL-D has gotten to the point that they have cirrhosis of the liver, would this medication be effective? Would that help them? Or the only solution is to have a liver transplant and then get on this treatment?
I haven't had experience with that late stage of using the enzyme replacement therapy. So I would say that I'm not sure how they would respond, especially if they have significant portal hypertension. I think that we may be too far down the road to have a proper evaluation for liver transplant and then explaining the risks and benefits like we would usually do for anybody who requires a liver transplant. But I would say it's such a rare situation, and I not having found it, I would approach it if I were to face such a situation with a case-by-case basis.
Just to echo that point, I mean, I would only surmise. I don't think we have enough data to really know that, but we know that in adult studies in LAL-D patients, that losing some weight, whether it be upwards of 10% can lead to some fibrosis regression. I think it's difficult to say in this genetic condition as far as reversal of cirrhosis. And I think we, as clinicians, approach this idea of reversal of fibrosis and cirrhosis, especially with a lot of extreme caution. Because we do know that there are risks of liver cancer in patients that have cirrhosis. So, until we know otherwise, and we have a lot of very good data, it's always best to be, I think, a little bit more on the cautious side and doing our surveillance for cancer as appropriate in those folks that have cirrhosis.
And since this is a genetic disease, really transplant is not going to cure the disease. They will give person a new liver, but the LAL-D is still there, correct?
Yeah, I think you're entering territory where there's not a lot of evidence. So at this point, when we are talking about liver transplant, the new liver will have enzymatic activity, but there's been trials before the enzyme replacement therapy was around with bone marrow transplant as well, of course, because macrophages are produced in the bone marrow and so forth. So there's even less data where you're entering now. Both a liver and bone marrow transplant have been attempted, but very few numbers to give. Again, this would be a discussion with your team at that point and open understanding of the risks and benefits to that individual.
And the reason that the LAL-D is sometimes misdiagnosed as fatty liver disease is because of the high cholesterol in blood tests. Is that what causes the misunderstanding?
Well, I think it goes back to what we were discussing before, that there's a lot more prevalence of obesity in our society, unfortunately, today, and that leads to liver affectation. Obesity leads to liver affectation with elevated liver enzymes and elevated lipid tests. Those are so common. And when you look at what is the presenting data that you would think about lysosomal acid lipase deficiency, they're the same. Slightly different in terms of which cholesterol subtype and triglyceride ratio and so forth, but that's where it becomes a little bit finding a needle in the haystack. Outside of the very acute presentation in infancy, so for example. So that's where knowing, and Dr. Chanda's question was very apt, I think, at least from my perspective, having tried and been successful in weight loss, but not seeing the improvement you would typically see in an individual with the weight loss in terms of the cholesterol, in terms of the liver enzymes, that should heighten our inquisitiveness towards finding a patient with lysosomal acid lipase deficiency.
Dr. Coley, something that I was also wondering about was in the, we have about maybe a 4-5% prevalence of lean MASLD in the US population. Is this something that we should also be thinking about in folks that are, of course, of younger age, maybe not responding to conventional weight loss, but also maybe in more lean patients?
I think that's not a bad subpopulation to maybe even bring up from the second line investigation to even maybe a first time investigation for LAL-D. Yeah, I agree with you. It's a good point.
Well, this has been a wonderful discussion. I really appreciate and understand now a lot more about this disease. And thank you so much, Dr. Kohli. I know you're very busy. I've been very busy this last week, and I appreciate your time and interest in helping us. And thank you, Dr. Chandna. We hope to do a lot more with you this coming year, 2026. And I want to thank Alexion, AstraZeneca Rare Disease, for helping us bring attention to this specific rare disease. So allow me to say a few words about what's happening for us, going to happen for us in 2026. We will have Health Fair and Walk for Your Liver Orange County in May of 2026. Health Fair and Walk for Your Liver Los Angeles, September 2026. Salute to Excellence in Liver Care, October 2026. Healthcare and Walk for Your Liver Pasadena in October 2026. We will continue hosting our monthly webinars, educational webinars with the help of our Medical Advisory Council members. Salute to Excellence in Liver Care that we will have in October 2026. This is the time that we honor the best of the best in hepatology and in nurses, pharmaceutical companies, and we also honor and work with a lot of patients and patient advocates. So every year we honor and give awards to the best of the best. So stay tuned for our upcoming for 2026. This year, this last 2025, we did about 15 videos of liver patients that shared with us their story, their own story about how they were diagnosed and what process they went through to actually get to the healing. We are on all social media, and our website, as I said, is liverhealthfoundations.org. So please visit us and find out about our upcoming events. So thank you for attending tonight's educational webinar. We hope you received the information you needed. Thank you, Dr. Kohli. Thank you, Dr. Chandna. We wish everyone a happy and safe Thanksgiving. May your home be always filled with love, health, and happiness. Good night, take care, and be well. Thank you.